Hello, everyone, and thank you for joining the 10th webinar in our Pandemics and Society series. Today's event is Health Equity in Pandemic Response, Lessons from Rhode Island. Today, we will be discussing how to embed equity, particularly racial equity, as a core value in pandemic preparedness and response. The conversation will focus on what can be learned from Rhode Island's experiences and applied to communities in the state and beyond. I'll now pass it to our moderator today, Dr. Jennifer Nuzzo, who is a professor of epidemiology and the director of the Pandemic Center at the Brown University School of Public Health, to get things started.
Hello all, welcome to our discussion. Equity is one of the core tenets of public health, and it should be central to how we build plans to respond to infectious disease threats. But as we saw in the response to the COVID-19 pandemic, inequitable access to resources and the application of public health interventions undoubtedly exacerbated the tolls of the pandemic. And we saw profound disparities in particular in the first year of the pandemic among Black, Latino, Native and Indigenous and other communities of color. And what this teaches us is that in order to mitigate the tolls of future pandemics and future biological crises, we have to center our preparedness and response efforts on advancing equity. It cannot be an afterthought. There is clearly a lot of work we need to do on this front, but there are also some important examples that we can learn from in this past COVID-19 pandemic and in other public health initiatives. And I'm particularly proud to be able to point to some compelling work being done here in our state of Rhode Island. Rhode Island, for those who may not have been following, during the COVID-19 pandemic, at one point in particular was one of the hardest hit states. It had the highest reported case and death rates per capita compared to other states. Some of this is because we're a small state, but nonetheless, there were profound tolls being reported here in Rhode Island. But what there were also happening here in Rhode Island were really strong and I would say innovative efforts to try to address these unfortunate trends. And as a result, Rhode Island has earned attention for some of these efforts, and in particular, received national attention for its Health Equity Zones initiative, which makes focused investments in bringing the community to the center of public health decision-making here in the state and working together towards eliminating health disparities. This was something I discovered in moving here and was particularly interested in learning more about it as a potential national model. And it has been said, and I hate to use the pun here, but Rhode Island tends to do this a lot, is that this state may offer a compelling roadmap of how governments, organizations, and citizens have historically responded to infectious disease outbreaks or other public health concerns, and how central equity can be to these decisions that are being made. And so I think that there are lots that we can get into to learn from, and I am very pleased to be joined by three great colleagues who have a wealth of experience in working on these issues here in the state, and they've engaged on these topics nationally. Today, we are joined in our conversation by Dr. Will Goodell, who is an assistant professor of epidemiology here at the Brown School of Public Health. Will's work involves frequent collaborations with the Rhode Island Department of Health and has worked on these issues in the context of COVID, but other infectious diseases. I'm also joined by Dr. Larry Warner, who is the Chief Impact and Equity Officer at the United Way of Rhode Island. The United Way of Rhode Island is a nonprofit organization that aims to connect individuals in the community to the social services that they may need, as well as address social inequities and advance racial equity more broadly. And thirdly, we have Ms. Michelle Wilson, who works as health equity architect and community engagement strategist. She leads a variety of health equity programs and policy initiatives to improve the social determinants of health. During the COVID-19 pandemic, she helped to implement strategies to support equitable response in communities adversely affected with higher rates of transmission, hospitalization, and mortality rates. Her work focuses on improving policies and systems to reduce post-COVID health disparities and improve future response capabilities. So thank you really to all three of you for joining us today. I'm really touched and heartened by your experiences working here in the state. Thank you for your work on behalf of Rhode Islanders, but also very eager to hear your reflections from these efforts in terms of what other states and other practitioners can learn from them. And before I start, just to say that I hope to just keep this conversation conversational. So please feel free to interact with each other. And we will have a Q&A, as we always do, at the end of our webinar. So anyone who is listening, do feel free to write questions in the Q&A function. We can address them later in the conversation. Maybe our panelists will see them along the way and choose to answer them. Let's just keep this as interactive as possible. Great. So I'd love to hear from each of you just a little bit about your work, just kind of set the stage for people who aren't familiar with your work here in Rhode Island, and just kind of give us the kind of high level description of how you would describe your work to others. And Michelle, since you're the top box, I'll start with you. I think you have mute.
I guess we have to turn the mic on, huh? We always forget that part. But no, thank you so much for inviting me to be a part of this conversation. I'm glad to be here with you and my colleagues, Larry Warner and Will Goodell. You know, my background includes 13 years in public health, and 6 of those years were spent in emergency response. And currently, a lot of my work now focuses on health equity. Have really loved the work that I do. The work that I do also involves engaging with community partners, community-based organizations, community leaders, really trying to make sure that the systems and structures that we have in place are not creating unjust and unfair outcomes for our communities, particularly communities where we know, you know, structural issues have led to disparities and or have exacerbated disparities in those communities. And I think we saw, you know, some of that really come to life during the pandemic. You know, in normal times, many of these communities are struggling. So in emergent times, you know, we're going to see far worse outcomes than we would, you know, when you know, things are normal. So love the work that I do. Love engaging with community, and just really a champion for you know, fighting for fairness and equity and racial justice.
Thank you for that championship. Really appreciate it. Larry, you're next.
Thank you, Jennifer. Thanks for the opportunity to be part of this conversation. And, you know, happy to share a little bit about my day-to-day roles and connectedness to community and different bodies of work. So at United Way, as you mentioned, I'm the Chief Impact and Equity Officer, in which capacity I oversee our grant making, our policy and advocacy work, research and data, and then our two direct services lines of service, our 211 Information and Referral Center, and our Senior and Disability Services. So a mix of community level and systems level work, as well as individual and household level interventions as well. And our vision is a Rhode Island where every individual in each community has equal opportunity for justice and prosperity. And so we are committed to that through the various tools in our toolbox as an organization, and then the different spaces that individual team members show up in as well, in volunteer capacities. I also serve as the chair of the Governor's Council on Behavioral Health in Rhode Island, and was previously a member and co-chair of the Commission for Health Advocacy and Equity. And so both through my day job, which I get paid for, and then the other spaces where I have an opportunity to show up alongside others who are committed to advancing equity in the community has been rewarding. And hopefully there's been synergy in advancing racial equity. And so look forward to today's discussion about the lessons learned during the pandemic and how we can share what we've learned and do better as a state as well.
Well.
Hi, folks. I'm really happy to be here. As introduced, my name is Will. By day, I'm an assistant professor in the Department of Epidemiology here at the School of Public Health, which means I do all of the stuffy academic things like teach and grade and things like that. But outside of that, I consider myself what I called an applied social epidemiologist. So I'm really interested, as all epidemiologists are, in the distribution of health and disease in populations and what drives that. But in particular, my work pays very close attention to social systems and social structures, and really does that in a way that's partnered with government, nonprofit, private sector in a way that gets data out into community so that the people that are the experts on their own lived experiences have the analytics that they need to be able to pair their anecdote, make their anecdotes that much more powerful when they're advocating for the kind of systemic changes that they want to see in the world. Most of that happens through wonderful collaborations with the Rhode Island Department of Health, but I'm a data nerd. I'm the kind of person that likes to be able to say, you're looking for data points to be able to support this kind of argument that you're building. How can I help you figure out what's out there publicly? How can you get better insights out of the data you collect as an organization? And how do you tell better stories with the data that you do have, so that everyone can kind of get on the same page with what the current situation is with regard to a health issue and where we need to go in terms of really transformative systemic change across sectors like housing, education, and workplaces. So that's what I do.
So we are now in 2024, so many years into the pandemic, and many people don't want to look backwards. We, of course, want to look forwards to thinking about, what work we can do to continue to protect our health of our communities going forward and also in future events. But I think it would be just helpful to kind of set the stage because memories sometimes fail us now, particularly 4 years into this. Just if you could each reflect on sort of your observations, like what happened here in Rhode Island? What were the issues that you saw? What have you witnessed? And in particular on this topic of equity and disparities, I'm sure you all have a slightly different lens through which you've looked at these issues. So I'd love to hear you kind of each reflect on your experiences. And you could start wherever, but maybe Michelle, if you want to kick it off.
Sure. So, as has been said, this was an unprecedented pandemic. This was a first for Rhode Island and states across the country. We've had experience with past disasters, such as Hurricane Katrina, Hurricane Sandy. We saw the impact of those disaster events on communities of color. So I think going into this pandemic, there was some acknowledgement that perhaps the outcomes for our communities of color would be more devastating than other communities, simply because after action reports, lessons learned have brought this, to light. The speed of the pandemic, I believe, superseded the thought of equity, embedding equity in the response. I do think that it was a consideration, but the goal was really to save lives, to try to get as much resources out into the public as we possibly could to do testing, et cetera. Just also reflecting on that question, there is, I think, in I call it public health speak, and there are conversations that we have in public health that perhaps do not resonate in other sectors. And so I think, if we're thinking about back 2019, 2020, there was a lot of conversation inside public health about racial equity, health equity, social determinants of health. I'm not sure if those concepts resonated perhaps in the emergency response world, although when you look at emergency response doctrine, there is that language, but to actually operationalize it, I think, may have been more of a theoretical concept than something that we really focus on sort of inside the public health sector. So I think that there may have been a little bit of tension in that as well. I think eventually we made our way to embedding equity in the response, and I believe going forward, that will definitely be one of the leading considerations. But early in the pandemic, it was, just about saving lives. And I think the state did a very good job with that. But we also needed to bring in that equity component because we saw that there were certain communities that were being adversely impacted more so than others.
I have some reactions to that, but maybe let some other folks weigh in on their reflections. Larry, do you want to?
Sure, I'll pick up where Michelle left off as far as the disproportionate burdens of disease and death experienced by different communities. It was interesting that we've learned a lot over the years about disproportionate impacts of chronic diseases, infectious diseases, and COVID-19 was sort of a it was new to the world, and it was a disease of equal opportunity, if you want to call it that, because nobody had had prior exposure to it, and anyone was susceptible to it. However, what we found was that it followed the same pattern of disproportionate burdens of disease, particularly with lower income households, people with limited English proficiency, people of color, and we saw both the trajectory of the disease course um, further magnified by individual and community level social determinants of health and health related social needs. And so sort of a convergence of multiple crises that led to what we saw play out in the data and in people's lived experiences. We implemented some innovative responses, both from a clinical perspective as well as from a social needs perspective. We saw systems that had not been implemented before around rent relief, and certainly federal resources through federal dollars did make it possible to stand up some of these new systems. But as the sort of active response to the pandemic started to scale back, a lot of these resources, which would benefit the community in being better prepared for future public health emergencies, have been removed or sunset. I think we're unfortunately seeing a regression towards the norm, which will likely set us up to see the same patterns of outcomes for the next public health emergency, whether it's pandemic or disaster or something else. I think the last thing I'll share is that we probably, well, I think we lost sight of or forgot that a number of people and communities have justified and well justified reasons for not trusting big systems and government when it comes to unknowns in public health. And we didn't do a good job meeting people where they were with the language that we're using. And I think it's been recognized as far up as the CDC and other public health national local stakeholders that we didn't do as a public health system a great job around communications. We overcomplicated putting into the layperson's universe, trying to navigate efficacy versus effectiveness of new vaccines. And if people don't get the difference or just understand that these vaccines are going to help you stay alive, stay out of hospital, then if they hear anything's less than 100% or 90 something percent, they're like, I'm not going to take that. And so it was, we played a lot of catch up in trying to get trusted ambassadors and messengers to help champion the vaccines as they were coming online, which was a great best practice, if you want to call it that, in socializing. These are resources that are going to help save your life or keep you out of the hospital. But I'm hoping that we don't lose sight of that lesson learned and both the implications that it had in delayed accessing of resources that are life-saving, in addition to trying to mitigate some of the social and stuff.
Well,
I think what most immediately comes to mind when I think about March to December of 2020 is just the real scarcity of resources that we had at our disposal in some capacities, that our ability to test, our ability to provide QI support, quarantine and isolation support, our ability to then vaccinate in late 2020 and early 2021 is limited by a highly constrained sort of pool of physical resources. Same thing with PPE, I should say also. And that a lot of our frameworks for allocating and distributing resources are usually like one of two models, right? There's the give everybody a share of something that's per capita, that if you've got 5% of your population in an area, give them 5% of the resources. Or if you've got 39 communities, like we have in Rhode Island, we have 39 cities and towns, and you're trying to distribute to all of them, you give them all some set amount, right? We didn't quite have a formula for resource allocation, knowing that some communities needed more of those things than others. And we were really just trying to blanket as much of Rhode Island with resources, I think, in some ways, as Michelle says, like save as many lives as we can. But I think there were probably many more lives that we could have saved with that kind of more, I think about it as like a really tailored resource allocation. But when I think about equity, I think about making the pie bigger, not necessarily having to slice up a pie more. And in that case, we had a a pie in a very tight springform pan, right? That wasn't going to get any bigger in a lot of ways. Our supply chain was really limited. We had to take sort of staged approaches to being eligible for certain resources, but that I don't think we could always collectively, either as a state or even across the country, prioritize what we maybe should have. We did a lot of like age-based prioritization because we knew the risks of hospitalization mortality were really high in older adults, but not also recognizing that high mortality or morbidity sort of risk is like conditional on being exposed to COVID. And so if we're not addressing the fact that some people are overexposed to emergencies, situations like COVID compared to others, we miss some really crucial sort of opportunities when we're just saying, let's go for all the older adults, not recognizing that, people in some parts of Rhode Island in their mid-40s and mid-50s had the same risks of hospitalization and death as older adults just because they were exposed to COVID so much more frequently than someone else. It's a matter of like whose priorities are driving the response, which I have a lot of thoughts on, I suppose, and we'll get there.
So maybe kind of actually starting with there, and Michelle, when you're talking about, and Will, you also mentioned sort of that the focus was on trying to save lives. I'm struck by, first of all, it took a while to start tracking the data with respect to like race, ethnicity, and other demographic factors. And when we started seeing those data show up that states were reporting, I'm curious how Rhode Island approached this. In my view, the conversation about them was one of like, retrospective, that's what happened, as opposed to we're using this information to tailor our response for the purposes of trying to target our very limited resources to save the most amount of lives possible. And if you looked at those early data, it was very clear that we were all not equally at risk from this virus, and that there were communities that were far harder hit, and I would argue were clearly more deserving of resources because of that increased risk. But that we weren't proactive, and I'm saying we here sort of in the national context. I wasn't living in Rhode Island in that first year, but just seeing that and thinking that these data should prompt action, use these data to guide how we target our resources so that we can connect what is ultimately limited with the areas of greatest need, to make sure as a matter of priority that we that we cover the hardest hit places, and then kind of work beyond that. And I think that's when we talk about centering on equity, is making sure that we go to where the need is. But anyway, I'm curious your thoughts about that, and just kind of, what were the data tracking efforts here? How are those decisions made? Just kind of continuing to kind of reflect back on that, the COVID experience, because I think this will then provide some important context for thinking about the initiatives that were put into place here. And whoever wants to chime in on that can feel free.
Sure. I'll say a little bit. I'll say this as an outsider that wasn't working in government public health right from day one, but was a partner from the beginning. But I think Rhode Island has had some of the most robust data systems from the beginning. I mean, everybody was standing up brand new data systems, I think, to be able to track COVID at the scale that it needed to be tracked and understand just sort of the overwhelming resource needs because our options at the beginning were quarantine and isolate and keep yourself comfortable separate from other people. So we have a lot more to keep track of when that's our recommendation, right? When it's not like get a prescription for this thing and move on. And that we had data available across all sorts of axes. I don't think that there was ever a point where I felt like we didn't have the data to act on in our COVID surveillance system or from lived experience prior to the pandemic. I make a lot of maps to help people make decisions, and I will always say that most of those maps are completely unnecessary, because if you know anything about history or policy or social structure, you will know where to focus if you pay attention a little bit more. The kinds of maps I make don't surprise anybody, shouldn't surprise anybody. But that I think it's a question of what your priorities are early on. Your priority, we had this balanced priority of like save lives, minimize economic fallout. And sometimes I think minimize economic fallout and to whom was the like more important question to be that was being asked sometimes. It was sort of like whose comfort matters the most when we shut down certain businesses versus and who gets to now access a amenity now that that's open versus like, do we want to center on the experience of the worker that now has to be in that store every day versus the consumer? I think they're like, we had plenty of data, but it's, you have competing interests. And not always a clear recognition that the groups that can represent those differing interests have varying amounts of power to exert on the response. A kind of a well-to-do consumer class has a lot more political and economic capital than people who are in survival mode. And it's the people that are in survival mode that we need to focus on. And we had plenty of data, I think, very early on that suggested that that's sort of where the most disproportionate impact was, but comes down to a matter of who gets to decide what's in the policy space, I suppose, when you respond to emergencies.
Yeah, well, you're sort of pulling thoughts out of my head as I listen to you. But I do want to acknowledge that, it was a public health crisis and it started within the public health realm, but then it was moved outside of public health and became a statewide response. So you're bringing a lot of different voices and players to the table that are making decisions. And I think we have to take into consideration, as Will mentioned, sort of these economic determinants that were at play. There were political determinants at play. There were social determinants at play. And there were other interests at play here. So, some of those determinants guided decisions, sometimes informed by data, and then sometimes informed by other priorities. We did have robust data. Those of us that were working in the equity space really focused on using that data to try to tell the story about what was happening within certain communities within the state so that the response could shift and more resources could be allocated to those communities. And we were able to do that successfully, perhaps not as soon as we had hoped, but we were able to get there and really be able to partner with cities and towns and municipal governments and community-based organizations and community workers and really get some momentum going in those communities, and then being able to take the data that we had, share it with our community partners in a way that they could understand and make that data actionable, thanks to a lot of the work that Will and his team did to help support those efforts. And I do believe that going forward, we will begin to use and look at data differently. But I also want to point out that, so the data is telling the story about the impact, right? Which is at the surface. I think we also need to focus on sort of those the drivers, right? Like what's in the groundwater, as I say, that's causing those inequities to rise to the top. And if we're going to change the impact, then we need to address those structural drivers now so that we can see a difference should we be in this pandemic situation, years from now. So what's happening in the housing space? What's happening in the education space? Are we providing paid sick leave to those that don't have it? And if we're not looking at those kinds of issues now, then, as has been mentioned, the outcome is going to continue to be the same.
So on that note, and Larry, don't want to cut off your opportunity to chime in on that, but I do want to talk about sort of looking forward in some of the initiatives that were put into place. And at the top, I mentioned the health equity zones. That was something that I was introduced to in moving here that I thought was particularly interesting. But I'd love to just hear about some of the initiatives that are in place in the state, and then what others who are listening who are not fortunate enough to live in Rhode Island can take from those initiatives, possibly think about applying in their own states if they aren't. Or anyway, I'd love to hear all of your thoughts, and anyone can kick that off.
Very good. I'll pick up on the health equity zones and some of the other more recent conversations and tables. So the Health Equity Zones Initiative, it's a place-based effort to address social determinants of health, or address health disparities by addressing root causes of social determinants of health as identified by the community in a contiguous geographic area. Initiative of the health department in partnership with local health equity zones, 5,000 residents or more. They identify the needs, they conduct a needs analysis, develop an action plan, and initiatives to address those root causes, whether they're environmental, housing, safe streets, behavioral health, you name it. The full gamut of behavioral health, of health needs and social determinants of health are being worked on by the health equity zones. They predated the pandemic by 5 years. So that effort, that body of work kicked off in 2015 with the first cohort of HESs. And I'm grateful for the infrastructure that it created in community, because with the support and leadership of the Backbone Agency and other community-based organizations and individual residents, it created a natural venue for systems to connect with community. And there's a lot of opportunity in that space with regard to getting insights on what are the things that systems, government, big organizations, for-profit or nonprofit, should be thinking about policy and regulation-wise to promote health equity. But it also created a conduit for information, bi-directional information during the response to the pandemic. Others on the panel may be in a better position to speak to it, but from what I saw, where there were gaps in information flowing from community to state decision makers or vice versa, the HESs created a space in the channel for that. And in many communities, there was sort of a self-created system for support and response to needs that residents were identifying, that other residents were helping to gather information and resources to help address in real time. So, definitely would pass the mic and welcome additional thoughts from Michelle, but just wanted to share that I know that as a member of the Commission for Health Advocacy and Equity at the time, engaging the HESs and other community residents and the community-based organizations was one of the key recommendations that we made as the state navigated the response and reopening and ensuring that information was accessible, resources were accessible and culturally and linguistically appropriate. And so rather than reinvent the wheel, we have this infrastructure that had been invested in and had been in operations in several communities for about 5 years up to that point. And then the last thing I'll say is that we have other conversations, other tables, other sources of community engagement, other standards that had been in place before the pandemic reached our doorstep. And then it felt like when this transitioned from a public health emergency to an all-of-government response, a lot of what would have been default ways of operating for people who navigate and operate in a health equity space or guided by health equity principles on a daily basis, these things went out the window. And so we unfortunately were left with, let's just save as many lives as we can, but not recognizing, like, if you take an equality approach as opposed to an equity approach to a pandemic response, you're going to leave people behind, and you're going to have the patterns of burden and death that we saw, and lack of information, testing facilities that aren't accessible by public transportation or in remote locations, even though the physical location might make sense. If you're thinking about where the burden of disease is most likely to be highest, with some of the mass testing locations that were initially implemented could have been better planned if we were thinking about accessibility as a consideration. So there, but I just want to share those thoughts.
Yeah, Michelle, I'd love you to elaborate on it for people who don't understand. Like, I have a, like, what is aside from a geography, and I'm struck by that Rhode Island, the small state in the country, that you are able to further divide to these very, on the US scale of things, very small areas that allow you to engage with communities, but sort of who implements it, who runs it, who funds it, just kind of, I'm getting into some of this nitty gritty because I'm sure other people who are wondering, thinking, oh, this is an interesting idea. How do I do it where I live?
Yeah, so I'll give an example. it might make it easier. So within a zip code, so I'll give my zip code. Well, no, I won't give my zip code. We'll give a zip code, say 02909,
Mhm.
for example. And within that zip code area, there may be a collaborative of organizations that come together. So, and there's a backbone agency, and so the backbone agency kind of serves as the fiscal agent. And then there are a number of community leaders, residents, community-based organizations, faith leaders, sometimes municipal partners are at the table. Will come together and do an assessment of that geographic area, say within inside that zip code. And that assessment will look at what are some of the health concerns, the economic concerns, what are some of the burdens, the barriers, and the challenges of that community, looking at a variety of social determinant of health factors. Once they do that community assessment, that is shared with the health department, and then through the health department, that health equity zone is supported with funding. And that was more so early on in the development of the health equity zones. Right now, the funding model is changing a little bit, but there is funding support made available to health equity zones to be able to begin to address some of those issues in their community. And that could be either, more downstream, looking at different programs that they can implement for residents in that community, or that could be more upstream, looking at how they can create policy change to create better outcomes for the residents in those communities. It's a great way for the state to be able to tap into individuals who know, who's in their community, the cultural, social norms that are in those communities, who the trusted leaders are, where the assets are, and the response infrastructure for the state was able to tap into our health equity zones, because we needed to be able to operationalize the response. There weren't enough bodies to be able to go out into community, to really reach into neighborhoods, to engage people for testing, to share communications, to be able to translate communications in ways that people in those communities could understand, to be able to bring resources, do food deliveries, provide guidance. And so that's really the role that our health equity zones played. But we also had other partners at the table as well that maybe were not part of a health equity zone, but were also doing a lot of work, inside community. And definitely want to give a shout out to community health workers as well, who are very much embedded in many of our health equity zones, who did some really great work. I call them boots on the ground. They should be deemed, in my opinion, first line responders as well.
So I want to remind attendees, please feel free to type in the chat any questions you may have. We'll try to get to them. And but Will, maybe I can turn to you. So what I'm hearing about the health equity zones is I'm hearing sort of a place-based unit for identifying vulnerabilities, sort of trying to understand what are issues in communities. I'm hearing a government resource extender in the sense that it involving community engagement and other partners in the work that may be led by governments in some form. Hearing a kind of a communication hub, the involvement of trusted leaders. Also, I think an important communication conduit back to, say, official response structures. This is what's happening in our communities. This is what's working. This isn't working. What else, Will? I know you do a lot of work in sort of, you are a place-based epidemiologist, work of sort of trying to connect, identifying where the needs are and trying to figure out how to target resources. What else did we see? And any examples of how these initiatives were used in the work of responding to the pandemic would be welcome.
Yeah, I think one of the most valuable sets of experiences that I had as an epidemiologist were not inherently like what data things I got to do. I got to do some cool analytics, which was like fun, the nerd brain side of me, but really what it challenged me to do better and to do regularly was once a week, twice a week, there were meetings where all of our stakeholders got together and they expected updates not only on how is the state of things epidemiologically shifted, but how have changes in things that we did around communication, around resource allocation shifted people's actual use of those sort of resources? It's like, okay, great, you can tell me how many people were tested per capita, but did we see any shift in like my community that I am holding you to task for? I think those were some of the most valuable experiences because it kept me at least laser focused on what our community partners needed to hear, what they needed, it's often they're so busy, they're doing so many different things that being able to take credit for all of what they do is like not something they often stop to do, but to be able to say, look, you popped up this clinic and I can help you keep track of how many people came in through the door, to say that you shifting in this way meant that we got 100 more people vaccinated this week than we did last week. That probably wouldn't have otherwise happened. And I don't think we got it perfect, but there's often a very, very big imbalance in availability of data and information for people inside responses that are usually government led and outside of them. And some of our like best efforts were through these kind of place-based partnerships. They allowed us to directly communicate information back out and get information back in. There were teams that were that are still holding regular office hours with community partners to be like, this is what data is telling us about right now. What are you seeing? How does that line up? How does it not? What's your plan? Getting people to realize that giving people a couple tools to say, you know what a counter rate and a percentage are, lifts them up to be able to talk to public health people very directly. To be like, okay, so you told me that the rate is this last week and it's this now. That didn't go down like I want it to go down. So what do we have to change? I think that data sharing out to community is something that we can't be scared of. People can understand all sorts of quantitative concepts if you take a minute to just explain to them what it means in a way that they understand. It doesn't like epi does not have to be this thing that like lives in some government agency that people don't know what it is. It's a way of thinking to me that it's not any one set of quantitative tools, that if you think about what drives health in your community, you are thinking like an epidemiologist. And so you have the ability to tell other epidemiologists almost, I think about it as speaking peer-to-peer when I talk to my community partners. You tell me what your sense of what a cause is and what we need to do about it. That's what I do as an academic epidemiologist. They're doing it out in the community, so we should be in conversation with each other. But it's that we prioritized having like regular venues for that kind of communication, I think was huge. And it's because of the kinds of investments that we had done up front. Health equity zones are our modern version of them, but I really do think of them as a natural follow of, Sidney Clark and community-oriented primary care and lots of sort of public health neighborhood centers that existed in the 60s. Like, we're really kind of taking this forward into its kind of modern version where we recognize that community is broad. It takes a lot of sort of multi-sectoral action to make systemic changes that impact people's health. And we made those investments up front, or started to. And I hope that we can continue to do so, because I think paying our experts is the biggest thing that we can do. Compensating them for the fact that they can show up to these meetings and give us insights that would have taken us weeks to figure out, because we're in our own blind spots.
Yeah.
On that kind of, oh, go ahead, Michelle, go ahead.
Someone saying, that bidirectional communication was so important. And, the data that was provided could be tailored to our health equity zones, really at the neighborhood level. And then, combining that with the visual tools that were developed so that people could see. So it's one thing to give people data, but then you can take that data and turn it into a picture that people can understand and really see what's going on within like census blocks within their community, is a way that you can then deploy community health workers and HESs into the community, because they know exactly where they need to go. They know who lives there. They know the infrastructure there, and they know what tools and resources and ways that they can do outreach to be able to create change, in those areas. And that was very powerful. And as you mentioned, to create opportunities to hear from our community partners, because there were decisions that were being made at one table and they played out sometimes differently in community. So to be able to hear from our community partners that things may not have gone as folks intended that policy to be, was also very important. And then we could make those shifts within the response infrastructure to address those some of those barriers and challenges.
It's really interesting, kind of very dynamic, responsive approach, which I wish there were more of in terms of using data in the pandemic. But I do think that if there's a point of light in the pandemic, it's that I think we've changed norms about data accessibility, that there, I think now is an expectation that the data will be accessible. I think that the HESs are a nice platform for sharing those data and the interpretation and having a conversation about then what do we do about the data. So that to me is a really interesting approach. I'm seeing a bunch of questions come in. And one is a statement just acknowledging the important role of CBOs. I'm guessing it's community-based organizations that they played. So good to know that that was involved, and would welcome some of your thoughts on that. But I'm just scanning down some of the questions, and I see some commonalities, and a number of them are about sort of lessons learned. One question in the separate chat here about vaccine uptake and were there things you would do differently next time? But there are other questions here about sort of, best practices and lessons learned. One of the questions is, to what extent are states collaborating with each other after the pandemic to do that? But anyway, welcome your thoughts, each of you or any of you, on sort of lessons learned. What do you think we should do differently? What's your kind of big takeaway on that front? I'm sure there are a lot, but if you kind of what floats to the top of your lists?
One thing that comes to mind is the reminder that public health does not happen without the community. It does not happen without community-based organizations. And anyone who assumes that public health only happens when you have X amount of infrastructure from a state system or municipal system or health systems happening and doing things to the community is sadly mistaken, to be honest. And we've seen the importance of partnering with the community, with individual residents, and with community-based organizations, both in sourcing information but also playing it back. This is what the quantitative data is telling us. Let's combine that with the narrative and lived experience or qualitative data from the community to see, are we missing something as far as interpretation, and translating that into action and policies or programs. Unfortunately, when we make the mistake of solely relying on what the raw data tells us, we may end up making decisions that adversely impact communities and individuals, and can worsen conditions on the community level. So the last thing I would peg on the CBO comment is that government can't successfully complete its mission without the partnership of community-based organizations, whether it's through the health equity zones or other efforts. Nonprofit organizations are an important part of our community's infrastructure, as we saw during the pandemic, and just wanted to highlight that. And at times can be more nimble and community friendly than a government entity that's attempting to interface with the community. So just wanted to honor and give a shout out to all of the community-based organizations that played a role during the pandemic response and continue to play an important role in of promoting healthy communities and thriving communities. The other thing I'll say, and then I'll stop, is one lesson learned, I think, and it may have been in passing, but when the vaccine registration process went online, there was a requirement that people who were signing themselves up had to have an email. And that did create a barrier for significant segments of the community, either who did not have internet access or didn't have an email address, or older adults who may have not engaged with technology for personal use like that. And so just rethinking about what are the minimum requirements that need to be in place in order to have people access life-saving interventions, medications, vaccinations, preventive or treatment otherwise. So that was something that fortunately we were able to course correct, and people who were unable to navigate online. Fortunately, United Way partnered with the Department of Health on establishing a vaccine line, both through the Department of Health and then also through United Way's 2-in-1 line. So people could call and sign up for, or get assistance in signing up for a vaccine, whereas they might not have been able to navigate the online registration process themselves. So just think about what are the barriers, intentional or unintentional, that are created when we're designing interventions, and how can we ensure an equitable response by making sure that we minimize or reduce their removal of barriers.
Yeah. Well,
I think if I were to think about vaccine uptake specifically, just seeing because there was one question that grounded me there. Thinking about other sort of systemic changes that we needed to make. So Larry, I appreciate all of those comments on just sort of like getting signed up in the first place. But I think about people's ability to like make and maintain appointments is largely driven by, do you have time off from work? Do you have someone to watch your kids? And that we were maybe not as attentive to those structures, that something like paid sick leave is a pandemic preparedness measure, whether we think about it directly that way or not. Having accessible and affordable childcare is a pandemic preparedness measure, whether we think about it that way or not. And that those are probably some of like people's lived realities that we did not attend to in our rollout. Sure, we had partnerships with plenty of employers. I know the network of places that we offered vaccines in Rhode Island is one of the most expansive I could have ever imagined. We gave vaccines in every corner of the state, that if someone was willing to let us be there collectively as public health workers, we were there. But that some industries, I think, are harder to take that kind of like, let's vaccinate you on site at your job site kind of approach. That works really well for healthcare workers and for people who all work at one job site. But I think a lot about construction workers, home nursing services, anybody that's got a dispersed work site, those like, we're going to have a clinic on one day during work hours kind of approach doesn't quite work for them. So you need mechanisms for them to be able to get vaccinated outside of work. And if we don't have childcare and you don't have paid sick leave, that's really hard to do. So getting creative about how we, short of mandating that everybody has a minimum amount of paid sick leave as a worker, regardless of how much they work or what industry they're in or what their employer wants to pony up for, we need to have some sort of system that attends to that. And that it recognizes just that different jobs have different realities, and that we can get a lot of kids vaccinated through schools. We can get a lot of older adults vaccinated through things at their homes. There's a lot of people that benefit from housing-based vaccine programs, but work is such a crucial part of everybody's lives that we maybe can leverage that space a little bit better. Recognizing that like a well-vaccinated workforce is one that's not sick as often, that then allows people to like to not have like a supply chain crunch, or lets people have, the experiences out in the world that they want to have. I would have maybe hoped that, the advisory committee on immunization practices would have come down a little bit stronger on prioritizing certain groups of workers early on beyond healthcare workers. I think that was a big discussion early on of like who kind of counts as essential, and this sort of deeming certain types of work essential, but then not valuing them monetarily is like a very tricky space to navigate that I think we really have to reckon with going forward.
and I think some of those observations about the importance of paid leave and the critical importance of childcare had relevance to even prior to the availability of vaccine, ability to isolate or quarantine at home, compliance with the contact tracing efforts. And also, one of the kind of challenges of closing schools was the disproportionate tolls on communities that then had to cobble together care while they still had to go out and power society, despite the fact that their kids couldn't go to school. So we saw unfortunate data about contact rates in those communities being increased during that time. So yeah, larger, broader lessons here. We have just a few minutes left, so about 6 minutes left. A few other questions here, and also some observations. One question about any takeaways on working with youth and adults in custody, and interacting with populations imprisoned. And there's one question, a couple of questions about funding that I absolutely want to get to. So anyway, any quick reactions on the question about youth and adults in custody? It may just be outside of your experience. It's okay. Just anything to share.
I just want to give one shout out about the paid sick leave to the state of New Jersey, because they
My home state.
They recently passed some legislation mandating 40 hours of paid sick leave, regardless of whether you're a part-time contractor, temporary, or full-time worker. And that was to kind of address the issue that we just talked about not having access
Yeah.
to sick leave if you get COVID. And I believe it passed in 2023. So that is a great example of structural change that benefits everyone. So I really want to kind of give a
Yeah.
shout out to that work and
Great.
the great job they did in getting that legislation passed.
Great.
I
Um,
don't have direct experience or expertise in people in custody or prison industrial complex, but I would say that it's important both from a programmatic and a data perspective to not lose sight of those populations. Some of our more commonly used data sets don't include institutionalized individuals, whether they're in, I don't know that nursing homes is included in that, but certainly people incarcerated are not counted among some of our more commonly used data sets. So that can be problematic when we're thinking about disease burden and where interventions are needed. Resources need to be allocated. So I appreciate the call out there, and it's something that we do need to make sure that we're having the right people around the table from an input and decision making perspective, and then not missing those data.
Right. So I'd like to talk about funding. There was a very specific question who fund the HESs. But Larry, you talked about how these predated the pandemic, and it was great that when the pandemic happened, there was this infrastructure. There is a comment also in the Q&A box about the funding uncertainties about these efforts. I'd love your all in the 3 minutes we have left, just kind of quick takes about funding and the importance thereof to the extent that you're able to speak about it. It continues to frustrate me that we find all of this great importance in the midst of a crisis, and then afterwards we dismantle all the things that we know work. So we'd love to hear your thoughts, and whoever wants to chime in quickly.
The funding landscape for HESs has been very interesting. It was an innovative model in general, innovatively funded, but braided funding from various federal funding sources and program lines that were not typically aligned, but when you braid them could support a body of work that is addressing multiple areas of health outcomes and health determinants. There has been some philanthropic funding along the way as well. However, I think there's an opportunity to recognize that addressing health equity and the root causes, social determinants of health, that's a long game. And so it requires long-term investment. It requires long-term systemic changes. The inequities that we see now have taken decades and generations of being in place, the root causes of those disparities and inequities being in place for us to see the outcomes that we're seeing now. So it's challenging to think that with the time horizon that we've had for the implementation of the HES initiative, to say that we're at the finish line after even 9 years of work, that we're fighting up against decades and decades of systemic barriers to health and to equity. So it's a body of work that needs to continue. We need to figure out how to invest in it. We also need to figure out how to evaluate it. It needs to be, there is a body of work around evaluation, and we need to look at the evaluation of the implementation, as well as the evaluation of the outcomes, both health disparities and social determinants of health, or disparities in social determinants of health. So I think it's a combination of how we're using the evaluation process and tools to inform decision makers and funders that we're not, in some areas we may be seeing progress, in some areas we're not there yet, but it's a long game.
I think that's a great place to end, sort of painting the path forward. It is in fact a long game. I'm very heartened though that we are kind of gathering important insights to figure out how to play this long game. But there's clearly much more work to do. I'm very thankful to you all for your work here in the state, but also your willingness to take time away from that very important work to share your insights with others on this webinar. So really thank you to all of you for this conversation today. It was, I continue to learn a lot about these efforts, and I think there's very important significance for our approach to preparedness in this country, as well as other places. So really, thank you for that. I'd also like to thank my Pandemic Center colleagues who helped put this event together: Bentley Holt, Leah Lovegren, Carly Gasca, Andrea Ulig, and Aquil Person. Thanks for the team that makes these events happen, that now 10 in and more to come. And finally, if you would like to share this event with anyone who's unable to attend, the recording will be posted on the events page of the Pandemic Center website in the next week or so. You can also find recordings of our previous webinars there. We're about a year into this webinar series, so there's a lot of content there. And please follow us on our social media accounts to learn about this and future events to come. And there's also an email address on screen if you have any questions or suggestions for future webinars in our Pandemics and Society series. And with that, stay well, stay engaged, stay healthy, and thank you.
Thank you so much.